I would like to welcome you to the symposium, Building a Gastroenterology Center of Excellence with a focus on medical service lines within gastroenterology. This is meant to complement the endoscopy and hepatology symposiums that are a part of this comprehensive conference today. I am Dr. Jami Kinnucan from the Mayo Clinic in Jacksonville, Florida, and I'm excited for this program that we've put together for you today. I am joined with colleagues from all over the country, each at Centers of Excellence, to speak on their own particular clinical focus. I'm a senior associate consultant and specialist in IBD at the Mayo Clinic, and I'm going to be speaking to you about gathering resources to build an inflammatory bowel disease center of excellence. Dr. Walter Chan is an assistant professor and director of the Center for Gastrointestinal Motility at the Brigham and Women's Hospital, and will be speaking to you about multidisciplinary care through a comprehensive neurogastroenterology and motility program. Dr. Neil Sengupta is an assistant professor and director of quality improvement in the GI section at the University of Chicago, and will discuss colorectal cancer screening, a review of practice guidelines and tips to building a successful screening program. Dr. Venkata Ashkintala is assistant professor and program director for the Medical Pancreatology Fellowship at Johns Hopkins Hospital. Kelly Isaacson is an experienced registered dietitian and specialist in the management of patients with GI disorders and inflammatory bowel disease at Cedars-Sinai in Los Angeles, California. And last but not least, we will hear from Dr. Megan Reel, who is a GI psychologist that specializes in psychogastroenterology and is the clinical director of GI behavioral health at the University of Michigan. One common theme that you'll see throughout today's discussions is the importance of a team-based approach to care. So sit back and enjoy as we take you through building a gastroenterology center of excellence. I will be first speaking to you about gathering resources to build an inflammatory bowel disease center of excellence. Building excellence, not only with inflammatory bowel disease, but really this can be something that you think of for all clinical focuses, comes down to three key components: the patient experience or clinical care, research, and education. In this model, this is what we do at the Mayo Clinic. We really have built a foundation on these three important shields. Clinical care really starts with some essentials: access to specialized gastroenterology care. This can be both in person or it can be virtually. Ideally, you'd have access to somebody who has more advanced training in inflammatory bowel disease or has spent more time taking care or has a particular clinical focus in inflammatory bowel disease. We know that just as important as clinical care is the interim support care. So nursing partners, our medical assistants, support staff, and the scheduling team are just as important in making sure that the patient has an excellent clinical experience. Endoscopic imaging and pathology evaluations are of equal importance when caring for patients with inflammatory bowel disease for both diagnosis as well as for disease monitoring. And of course, infusion-based therapies, as well as access to specialty pharmacy for non-infusion-based therapies. And then clinical trial support or access to clinical trials really rounds out these important clinical care diagnostics and therapeutics. I want to walk you through what a specialized IBD visit looks like in my practice. Really, we need to understand the patient's experience with their disease. We can gather this at the time of their visit, asking them how they're doing. But in a more perfect world, we're gathering this information before they've even come to clinic using patient-reported outcome questionnaires, which I'll review shortly, and looking at clinical indices. I review any up-to-date labs in the last 3 to 12 months. And these are some of the labs that we focus on at each visit. I look at their last objective assessment and whether or not they've had a fecal calprotectin imaging or endoscopy. And based on their laboratory evaluation, their clinical symptoms, and their endoscopic or objective assessment, understanding if their current treatment plan is effective in treating their symptoms as well as their inflammation. If they have persistent symptoms in the absence of inflammation, really digging down deeper as to why that might be. And then after we've done all of that, we look at health maintenance and we provide patient-based education in the office. And yes, this does seem like a lot to all accomplish in one visit. However, you can be more efficient if you start to gather that data before the visit using patient-reported questionnaires or outcome measures. When we look at clinical indices, the validated clinical indice that we use at Mayo Clinic is the Simple Clinical Colitis Activity Index. and this is the SCC-AI. In Crohn's disease, we're using the Harvey-Bradshaw Index, or the HBI, to be able to put more validated quantification on patients' symptoms. Then there's a lot of patient-reported outcome measures that have been validated in inflammatory bowel disease. The one that we focus on at the Mayo Clinic is patient-reported outcome measurement information system, or PROMIS questionnaires. And it looks at various domains that have been studied in IBD, including anxiety, depression, fatigue, sleep disturbances, social role satisfaction, and pain interference, and overall gets at their patient's experience with their disease, as well as the impact on their quality of life. You can see a common theme in a lot of these patient-reported outcome measures is that they look at quality of life in patients with inflammatory bowel disease. After looking at some of the clinical care and diagnostic testing, we need to be able to have access to laboratory evaluations. That includes some of the basic labs, as well as drug monitoring labs for some of our biologic therapies, as well as thiopurines, and labs that we look at for pre-treatment. In addition, things like fecal calprotectin or non-invasive biomarker assessment, and then stool infection evaluation, looking at C. diff, stool culture, and in some centers, we have availability to do GI-PCR testing. Imaging and access to high quality imaging is important. My preferred imaging strategy is MR enterography because of the lack of radiation. The Mayo Clinic is starting to pilot and look at intestinal ultrasound for the bedside evaluation of Crohn's disease and inflammation. And lastly, looking at endoscopy and multiple endoscopic assessments, not only just our standard upper endoscopy and colonoscopy, but being able to do more specialized exam like pouchoscopy or deeper enteroscopy or endoscopic ultrasound, especially in perianal fistulas. Clinical care is really all about the team. While I put at the center the inflammatory bowel disease physician or GI physician or an advanced practice provider, and here in the US, we use nurse practitioners and physician assistants to help partner with us in our practice. It really is about the nursing support, nutrition team member, and you're gonna hear from Kelly Isaacson in a little bit, psychogastroenterologists, people like Dr. Megan Reel, colorectal surgeons, consult services, and pharmacy services that really round out the full care team approach. Dr. Miguel Reguero and colleagues, who currently is at the Cleveland Clinic, had built the IBD Medical Home. And if you haven't had a chance to read the article, it's from CGH from 2017, and looking at how you build an IBD Medical Home to best care for patients. They did find that using this IBD Medical Home and centralized care for IBD patients help reduce healthcare costs, as well as utilization of the healthcare system, as well as hospitalization in patients. So this is something to look at and read about in CGH from 2017. While we've come a long way in how we manage inflammatory bowel disease over the last 20 years, some patients still require inpatient care. Access to a specialized gastroenterology team in the inpatient setting is very important for overall care for patients. Ideally, if you had access to a consulting specialist in inflammatory bowel disease, whether or not that was in person or via e-consult services, that's something that would be incredibly important, especially in more complex IBD patients. We always want to partner with our colorectal surgeons in the inpatient setting when needed. And there's several quality metrics that we've looked at here, including the importance of Clostridium difficile infection evaluation, as well as CMV, and the importance of DVT prophylaxis using pharmacotherapy. In clinical care, preventative care is just as important as managing disease. And so the Crohn's and Colitis Foundation, which is based out of the United States, put together this amazing checklist that helps make it easier for both patients and providers to stay up to date on health maintenance. We know that we focus on vaccinations in patients, especially those that are immune compromised. It's important to and have intervals for cancer screening, including skin cancer, cervical cancer, and female patients, as well as colorectal cancer. Bone health assessment is important, especially patients who are exposed to corticosteroids, malnutrition screening, tobacco assessment, and last but not least, mental health screening should be done in all patients on an annual basis. As part of clinical care and diagnostics, it's really important that we standardize our endoscopic reporting. Using validated endoscopic measures for both ulcerative colitis. Here we use the Mayo endoscopic score, which you can see here is a score from 0 to 3. As well as for Crohn's disease, we use the simple endoscopic scoring system for Crohn's disease, which is called the SES-CD index. And this gives you objective scores that you can follow over time for both improvement of disease, as well as to look at actual healing. We know that patients with endoscopy often require deeper levels of sedation than our general population patients. And we know that in endoscopy, we have to have the ability to have access or refer out for endoscopic specialty services, including video capsule endoscopy to assess for mid-small bowel disease, deep small bowel enteroscopy in patients who need diagnostic evaluation or even therapeutics like dilation, balloon dilation, as well as advanced therapeutic options. Clinical care is really at the forefront, but research can happen alongside clinical care and is just as important. Research can happen in many capacities. You can gather data from using patient remote monitoring, and this is looking at patient-reported outcome measures, and you can look at patients over time. Enrolling your patients in either a database or a clinical registry when they come to your clinic. Having access for clinical trials really is able to provide therapeutic options for patients. Clinical research, as well as translational research. And last but not least, with a focus on education, both provider and patient-focused education, patient office-based education, as well as community outreach are really important in the care of IBD patients, as well as partnering with both local or national or international organizations like I've listed here. It's always an opportunity when we see patients to provide education to the referring providers, as well as even providing advanced level inflammatory bowel disease training, which is often offered at many centers within the US and Canada, as well as in Europe and internationally. And then, of course, social media presence. This is an opportunity to collaborate, as well as meet people from all over the world and countries to be able to collaborate on both research and clinical ideas, as well as share challenging cases, and an opportunity to both do provider and patient-based education. If you are on social media, I hope that you follow me at IBD Jami, and I look forward to partnering with you in the future in the care of IBD patients. Thank you for your time and enjoy the rest of this symposium.